Okay, so spinal trauma, super common in animals. Obviously, some breeds are overrepresented, dachshunds being the poster child. The most common causes we see are intervertebral disc disease, fibrocartilagenous embolism, and then several flavors of vertebral body malformations. There's a lot of these. I'm just going to cover them very superficially. A lot of them are congenital. Sometimes they're heritable. Sometimes they're spontaneous. Kind of depends on the species and breed. And these are most common in horses and dogs. IVDD. All right. So your intervertebral disc is a squishy shock absorber. It's the nucleus pulposus under pressure inside fibrous container, which is the annulus. So dorsally, this annulus is weakest right here. It's thinnest. This is the weak spot. So when there's trouble in here, stuff is going to go up. Herniation usually occurs dorsally because this is the weak point. And just quick review, we've got type 1 disc disease where you've got an actual extrusion of disc material. This one's like a bullet, and then type 2, which is the slow compression, just protrusion into the canal without actually rupturing. All right, so type 1, you guys can tell there's a lot of music references. I just got back from a music festival in California, and I'm like, so everybody knows who that is, right? Okay, good. It's fine if you don't know ICP. They're not even any good. They just all right. So type 1, this is the bullet. Things are under pressure in there. So this is chondrodystrophic breeds. Dachshund is the poster child. And the pathology here is degeneration of that nucleus with eventual mineralization and chondroid metaplasia. So they're chondrodystrophic. They have abnormal cartilage growth. They get chondroid metaplasia. You guys remember what metaplasia means? Sort of one tissue type turning into another tissue type. And when you lose that squishiness, you don't get any shock absorption. So this results in explosive herniation of that hard bullet-like nucleus through the annulus dorsally, because that's where it goes. And it's like a bullet that goes into the spine. This often occurs while the animal is in periods of high activity. So they're running around, jumping, and then suddenly they're paralyzed. There's a dorsal spinal ligament right here. This provides minimal protection from this type of energy. So for injury, sorry. But just because of the energy of the material that's going up through there, it's literally like a gunshot. So it just rips right through it and goes into the spinal canal. This is different in type 2, right? Because this is a slow push. That ligament actually does offer some protection. So this usually presents as a rapid onset spinal lesion. It can be compression in less severe cases, actual laceration, so actual traumatic injury in more severe cases. And you can get a full spectrum of lesions from mild compression and degeneration to actual necrosis, myelomalacia. The other thing with these types of injuries is because of what we talked about, all the hemorrhage and edema and swelling in there, the injury actually is focal, but it becomes a little bit ascending and a little bit descending. So the initial presentation, they can actually get more severe because that injury can worsen a little bit. And then usually it progresses for a little bit and then usually stops. But these lesions can be quite severe. So clinically, these are going to present acutely, often very severe sudden paresis or paralysis. And in the initial stages, especially, it may be progressive. Here's what that looks like. Here's the poster child with the poster child presentation. And here's what that looks like radiographically and pathologically. So here's pretty normal nucleus. You can see it looks like jelly, nice and squishy, shock absorption. Here's kind of early degeneration. Going down here, you can see here it's starting to actually burst through the annulus. So here you can still see annulus containing it. Here it's like, oh, where's that going? Here's a more severe, and then here the disc material is actually gone. It's left the space. It's like when someone, as a kid, made you put water in your mouth and then you to their cheeks, right? Except if they had marbles in their mouth instead of water. The space in front of them was a spinal cord. That metaphor went off the rails. All right, type 2, this is the bulge. There's no breed predisposition, but this occurs in older animals. So this is a more of a degenerative type disease than a broken type disease. So this is normal. We see this in humans too. You get age-dependent degeneration of the nucleus, just like age-dependent degeneration of literally every other part of the body. You'll see. You got a couple good years left, but you'll see. So everything just starts kind of falling apart. This is part of that process. The dorsal spinal ligament often remains intact because this is a slow push, not really much to disturb that very thick ligament. And this causes this slow protrusion of both the nucleus and the annulus into the spinal canal. So the lesion here is usually compression of the cord without rupture through the annulus. So these are usually slow, progressive lesions, and this allows time for the animal to compensate. The lesions are often much less severe. These animals can go for years with quite severe disc disease if it happens slow enough. So this is going to be a more chronic, slowly progressive presentation, usually starting with paresis. All right, so let's describe the lesion here. What do you think about this disc space? Maybe a little small. What about what's the nucleus look like? It looks opaque. Yeah, kind of firm. What about this guy over here? I think we're in kind of a transverse cut here. So here's like where the nucleus would be starting, but we're kind of off to the side. So don't judge this disc space. All right, and the main show, where is the disc material? Right there. Found it.
Oh.
Yeah, it comes out and it goes right into the spinal cord. So here's the spinal canal. Looks okay, looks okay. Uh-oh, squash, right? So if this happened acutely, this is a very, very severe compressive lesion, right? So do you understand why this lesion is more severe if it happened quickly versus if this happened over many, many years? This dog might still be walking if this was a chronic lesion. If this is an acute lesion, there's no way this dog's paralyzed, right? Yeah.
Is it because with herbs have this around, or?
So it's not that they move around, it's that it's the type of trauma. So a slow compression causes at worst degeneration, right? And eventual loss. And your nervous system is very plastic. So if you are losing neurons slowly, other neurons can compensate for that function. Does that make sense? Kind of. So there's a lot of it's because your neurons are terminally differentiated. They've planned for this, right? So it's like everywhere's understaffed. Sometimes people have to do multiple jobs. It's like, okay, we've lost some people, Bill. You need to step over here and work the knee. Okay. Sorry, that's just how it is. And then once you get enough of those and you've lost enough neurons, you start to notice the short staffing. It's like, Bill, the knee's not moving. What are you doing? He's up here in the ear somewhere. Sorry, I'm so burnt out. Sorry, I might be projecting a little bit. Okay, so type 1 or type 2? Look at the nucleus. What's this? Where's the dorsal spinal ligament? Follow.
Snap.
I think this is a 1.
Yeah, what's the last one?
Last one was a 1. This material is gone. It has left the building. That's for sure 1. That's the cheeks of marbles. So this one, we've got a bulge, could go either way. We still have material in here. Let's look at the other spaces. That guy looks okay. That guy, can't see. So this one's a little harder call. I would say it's probably a type 1. I'm guessing. All right, so here we're looking downwards. This one's actually in the neck. There's the second cervical vertebra. We see chunks of nucleus, chunks of crunchy mineralized chondrodystrophic nucleus. Type 1 nucleus is visible in the spinal canal. All right, so here's an actual picture of a cord with a disc injury. So these are larger segments, these are more proximal, smaller segments, these are more distal. So this is probably like a lumbosacral injury. Here's the lesion. Looks focal, but when you look in cross section, there's been ascending and descending on the site of injury. So is this a type 1 or a type 2? You look at all the hemorrhage. This is an acute trauma. Don't usually see hemorrhage like this in a type 2.
So in type 2, is the nucleus also mineralized, or is that most of the
It is also
Cement
mineralized. Yes.
type 1, that you know.
This is one animal. So this, like, see how these sections are really big? This is like the top of the spinal cord. So these would be like cervical, thoracic, and probably lumbar back here. Especially important is this ascending and descending nature of the lesion that you can see across it.
That was my question.
I see some scowls. Yeah.
I really hear what you just said back here.
The ascending and descending nature of the lesion is very important.
Okay.
Is that what I said? Yeah.
It's type 1.
Type 1, yes. This is a type 1 injury because it's very severe. There's a lot of hemorrhage. There is ascending and descending myelomalacia. This would be an acute presentation. Type 1. All right, FCE, fibrocartilagenous embolism. So the presentation of this is kind of like an acute IVDD, but it is not related. Disease is not related. So the presentation here is not chondrodystrophics, but it is young to middle age, mostly large breed dogs. And the presentation here is acute spinal pain. They let out, usually the history is my dog was running around, it yelped, and then it went down. The yelp is often due to pain. Obviously, but I think it's also quite startling because it happens so acutely. The pathogenesis here, we're not really sure how the fibrocartilage material gets into the vessels, right? So the name says what this is. It's an embolism of fibrocartilage that goes into your spine. We're pretty sure it comes from the disc material. It may be developmental. We're not really sure how those fragments get there. But the classic result is occlusion of this ventral spinal artery right here, which if you follow this up, this is the supply for the gray matter horns. So the characteristic thing about this lesion is that it is gray matter specific in the spinal cord. You can see that down here. So this is also, because this is acute, this can also be an ascending and descending presentation. And here you can see kind of the main show is this focus of hemorrhage. It's right in this ventral gray matter horn. And if you follow these segments, it goes a little bit in both directions, a little bit cranial, a little bit caudal. So these are all one animal. This is thread looping through the spinal cord. Okay.
You have a point. This is called question mark. What is the question mark?
Oh, yeah. What would infarction of spinal gray matter result in? What would be the lesion? Gray is polio. Spinal cord is myelo. Death is malacia. Polio, myelomalacia. Thank you for noticing that. All right, so this is an acute presentation. It'll look like an acute IVDD, but it will be the wrong signal, right? It'll be like this is a toxin. This is a middle-aged Labrador. Yeah. The good thing about this lesion, this is a much better diagnosis to have than IVDD because these dogs often spontaneously recover for reasons unclear to me. Yes.
Infarction normally happens in matter events as possible. That it could go to a vessel that the blood the white.
Yes. Yes, I would say that is theoretically possible. Yeah. Only way to rule out FCE from IVDD would be with CT. That's a clinical question. Yeah, I mean, I would say histopathology and necropsy, but that is probably not the answer you guys are looking for. Yeah, I would say yes. I'll tentatively say yes to that because you would need to look at the discs. Are they normal? Are they degenerate? Is there evidence of extrusion, protrusion? And an FCE dog should not have those things. Tentatively, because I'm not clinical. You are welcome. Thank you for the question. Okay, spontaneous recovery is common. I don't know why, but this is a better lesion. Yeah.
Spontaneous recovery, like, does that have to be fairly quickly? The infarct would have been
From my understanding, it is often very quick. They usually do like weeks to months of physical therapy. Recover again. I've never seen one of these clinically, and I'm not clinical at all. So don't trust me when I'm not talking about lesions and death. Other questions on FCE? It's very interesting. So we don't know how the fibrocartilage gets there, but we know it's there because we see it. So this is the brain. This is the neuropill. It's the tangle of axons. We're down here in white matter. All of these open empty spaces, these are empty axon sheaths. So axons were here, they're dead, now they're gone. And this is blood vessel right here. This red stuff around the vessel is some hemorrhage, so there's been some hemorrhage, and the whole lumen of the vessel is full of this smudgy blue material, which is fibrocartilage. It looks like fibrocartilage, it stains like fibrocartilage with special stains. It's definitely fibrocartilage. Don't question it. All right, review of spinal trauma. So type 1,
Sorry, that was me.
RADs are used to screen for IVDD. There's a grading scheme. Thank you. All right, so signalment for a type 1 disc. Dachshund, yes. Chondrodystrophic. Things with tiny legs. Pathogenesis of type 1. The key gen path word that goes in the pathogenesis type 1. Chondroid metaplasia. Is it acute or chronic? Acute. What is the course? Is it static, progressive, recovers spontaneously? A little progressive, yep, because you get the ascending and descending myelomalacia. And then what's the lesion look like? I heard necrosis. Necrosis or malacia. I haven't talked about that yet, it's not fair. Malacia. So pathology is often severe. You can get a range, but it's often more severe. Hemorrhage, necrosis, ascending, descending myelomalacia. Right, we missed this one. This is a disc extrusion. The disc has left the building. All right, type 2. What's the segment? Old people. Pathogenesis. Is it metaplasia? Degeneration, age-related normal degeneration. Pure chronic? Chronic. Course? Progressive? Rapidly, slowly? Slowly, can they recover spontaneously? No. And the pathology. What's the lesion look like? Rich? Process? Badness? Mild, moderate, severe? Degeneration? Yeah. Pathology depends on how long it's been going on. You get compensation, so lesions are often much less severe than what's there. All right, FCE, what's the signaling? Young, large dogs, young to middle aged. Pathogenesis, big shrug, what knows? Acute or chronic, super acute, per acute even, and the course. Static, progressive, recovery, spontaneous recovery. Pathology, very specific. We worked it out together as a group. Poliomyelomalacia, very specific infarction of the gray matter of the spinal cord. I think we have enough photos of this now. We can share amongst yourselves.